So welcome everyone. My name is Cassie Lentz. I am the Director of Community Partnerships at Choice Regional Health Network. And I am here with my colleague Trish Surza. And we are also joined by Dr. Ben Miller, who is going to be sharing some information with us and helping facilitate what we hope is a really engaged discussion based on what we all are interested in and what we want to learn more about. So thank you for joining this free workshop webinar opportunity to dive into this topic of community initiated care. Like I said, I'm Cassie. I'm with Choice Regional Health Network. We are the ACH, Accountable Community of Health for Central Western Washington. And a lot of our work at Choice is based on connecting individuals and communities, health and social services, with the goal that everyone in our region has the opportunities to thrive and live a healthy life. And one of the reasons that we're here, that we're asking Dr. Miller to share with us, and why some of you may be interested in some of this work, is that at Choice, it's really important for us to create spaces for shared learning, especially around shared goals and vision. Some of our goals that you all may share are things around connection. Connection is really critical to health. That we want to work towards a system where everyone has what they need to thrive, that we know it means connecting both health and social services, and that's both formal and informal systems to support some of that work. And just a little bit of background and context to what brought us here is that in 2024, Choice convened several different partnership opportunities, one of which with our tribal partners, the 8 tribes and tribal nations in our region, about the health issues that were most important to them and talking about how we could connect and work together. And the other platform is a health equity cohort that we launched in the spring of 2024, where we worked with 10 community partners throughout our region to discuss the strengths, challenges, opportunities that present itself in working towards a more equitable system. Through that process, we identified some themes that are helping to drive our collective impact together. Some of those themes that you may see in the pieces that Dr. Miller talks about and will share at the end of this workshop about where we see Choice going next. Some of those themes really highlighted the importance of bridging formal and informal systems of care to improve health outcomes, the importance of centering belonging and mutual understanding across sectors, across areas of our region, and the importance of collective action via true community-led solutions around what the priorities are in their community, what the needs are, what the strengths are, and lifting up those community priorities. And so as the health equity cohort and Choice were working on these things together, one particular model that bubbled up that seemed to really hit a lot of the points that we were discussing was this model of community initiated care. And so we are really excited to have Dr. Miller here talking about this model and what it's looked like in his work, and for us all to engage more in that and talk about what it could mean in our work together. Let's see where it left off here. Okay, so a little bit about Dr. Miller before we launch into the topic at hand. Dr. Miller is a clinical psychologist by trade. He is an academic, an executive, and a policy expert, and he's been working over the past several decades to prioritize mental health in policies, programs, and investments. His work is really at the intersection of policy and practice, ensuring that mental health and substance misuse solutions are a focus in our world. From Colorado, Dr. Miller transitioned to help start the Wellbeing Trust, which is a national foundation that focused on advancing the mental, social, and spiritual health of the nation. And under his leadership as president of the foundation, the Wellbeing Trust helped invest in the creation of several movement-building organizations and reports that influence policy change and tools that could be used by communities to advance mental health. And so with all of that in mind, Dr. Miller has worked to democratize knowledge and programs for mental health with the end goal of all of us having more capacity to help each other. And he has co-led work on community-initiated care, which we're here to talk about today, that aims to strengthen communities to become the first, most immediate, responds to common mental health challenges. So we are really excited to welcome Dr. Miller and hear more about the work that he has done. He's excited to meet all of you and engage in what you're interested in. So with that, I think I will hand it over to you.
Thank you, Cassie. It's an honor to be with you all today. Thanks for taking just a few minutes of your time to talk about an issue that I think is really important to all of us. As Cassie mentioned, I mean, the goal of today is really just to really spend some time talking through an issue that I think affects all of us. A question that I ask routinely around the issues of mental health is, when was the last time you got a phone call, a text, an email from a friend or a loved one saying, "Hey, listen, I need some help." And did you know how to respond to that? Did you know what to say? Did you know what to do? And that whole notion of us not really always knowing where to turn for help really got us to pay a lot more attention around this concept of community initiated care, which I'll get into in just a second. But I think we need to really take a moment and just kind of step back and think about some of the problems that I think we've all inherited. I believe fundamentally, and this is the world according to Ben, having done this for a number of years, yeah, I think that there's an opportunity right now in 2025 to reimagine a lot of what care and delivery looks like in the US. We got through COVID, right? And we learned a lot about some of the fragile cracks in our system, but it also gave us a better chance to realize where there's opportunities in communities to really lift up new and novel ideas and strategies. This area that we're going to spend some time on today is how we can best empower individuals and organizations who are ideally positioned to best implement the strategies that can address issues around mental health. We call this community initiated care, but it's just really, frankly, when we get into it, it's kind of what we all should be better equipped to do just in general to help each other. So let's go to the next slide and get started here. So we have 2 hours together. And no, you are not going to have to listen to me and Cassie drone on and on the whole time. I mean, we've really designed something that's about dialogue. It's about allowing you all to connect with each other on issues that matter greatly to your communities. And so today, while we're going to focus on substance misuse and mental health, these strategies actually can be applied to a variety of health-related issues. It's just I'm a psychologist, as Cassie mentioned, so I'm a little biased here, but I do think that mental health is one of the most pressing, if not foundational, issues of our time. So our agenda is broken down into 3 parts. I mean, one, I'm going to get into some of the problem and some of the possibilities, and then allow you all to talk a little bit more about that. 2, we're going to do this intro to community-initiated care and some of the theory behind it and what it means and how we can better really connect our communities to our clinics. And finally, the last section is, this is great. I'm excited. This sounds so cool, but so what? We're going to talk a lot about how to take action. So on the next slide, please, let's get into our first section. Setting the stage. Okay, next slide, please, Cassie. So if there was one slide that spoke to the problem that I'm typically trying to solve, it's this one. It's that we've codified these structures that make it increasingly difficult for people to get access to mental health. For mental health, if you're in that system, if you're in that world, we've inherited these imperfect systems and structures that at one time was someone's best idea. I'm not trying to put them down. It was someone's best idea, 25 years ago. But what we have in this moment is that an opportunity to really build on something that now no longer works. It forces us to take a look and understand a bit more about the historical context of the decisions that were made. And when we do this, sometimes we get clues that can inform our thinking. So access is one of the most preeminent examples of what people will say they have a difficult time getting when it comes to mental health. And so for us, when you begin to kind of remove some of these barriers and get into some of these problems, solutions emerge. And many of you are already doing this. So I'm really excited to get into that. Next slide, please. So for so many reasons, there are a variety of reasons why people don't get the care that they need. Study after study after study shows that we're seeing in this increased need for people to get care, but they just can't get access to it. So consider the following, and these stats are written out here, but you can see the mental health and substance use crisis at the US is at what I think of a breaking point. The numbers do paint a pretty stark picture, especially with our younger generations. They're some of the leading cause of disease burden across the world, but also here in the US. Access to care is a challenge. 33% of those seeking care wait over a week for a mental health clinician, and that's an average. So that means some people wait a whole lot longer. And then only about 10% of those with a substance misuse need receive the care they want. It's about half of that for mental health. Barriers for this, which we are going to ask you about just momentarily, these are the obvious ones that you've probably seen. I don't have insurance. I can't afford it. The providers aren't there. I have to wait too long. There's high costs. There's stigma. These disproportionately impact a lot of our marginalized communities in ways that I think are quite, unfortunate. So even if we did all the things that we need to do, training more people, it still isn't enough. We have this massive problem of not being able to address the demand of services with the supply of who we have, which forces us to kind of get outside that box and think a little bit more about non-traditional solutions. We need systemic innovations, and we need to really rethink how our community can best really become like the front line of care delivery. And what does that mean? So next slide, please. Surveys have shown us, data points have shown this the problem, but as you can see here on this slide, this is work that I've done over the last several years. These are deaths of despair, so deaths to drug, alcohol, and suicide. And they've been on this very disturbing upward trend for almost 2 decades. The public is aware of this. Mental health is a top concern for many Americans, but I'm worried, my friends, that we are beginning to become a little desensitized to how bad it is. When we hear about another drug overdose death or another person that's died by suicide or another person that can't get access to care, it just feels like so much that it's hard to see like a way forward. And what I want to do today is really spend some time thinking about that way forward. So let's go to the next slide, please. So across the country, there are issues that we could talk about with the workforce. You can see the stats here. Half the country lives in a community that doesn't have a mental health clinician. I already mentioned about some of the wait times here. The shortage are problematic, and it means that it leads to so many folks not being able to get the care that they need. So if this is our backdrop and this is kind of our foundation, how do we rethink about who that workforce is and where they are and what they do? Next slide, please. So I think that this is largely the problem that we have to solve for today. So there's a massive supply demand issue. I already mentioned that. We've got more people who need help than we have people to do it. And while those statistics that I've just shown you are daunting, they're a true sign of the times. They often only really focus on finding the clinician. And once you get into care, there's other barriers like is the quality good? Are they in network? Whatever else they might have to deal with. What you see on this slide is something that we put in a paper that was adapted from the World Health Organization that looks at our workforce. It looks at the places that people go for care. And at the top of the pyramid is where a lot of us mostly think about where folks are going to get care. It's the specialty system. It might be the hospital, might be something beyond that, a residential care. These services, while life-saving for many people, are extremely expensive. And when you think about the frequency of need that people have for those services, they're relatively low. When you work your way down the pyramid, you might see where you fall in line. You might see a place where you fit in your work is. You actually see an increase in number of times that you're going to be able to encounter someone, but it also a decrease in the amount of dollars that it costs. So unfortunately, in healthcare, we've spent most of our attention, most of our resources on the top end of this pyramid. And I think that's a mistake. And at the bottom of this pyramid is where we really get into opportunities to achieve population health. We get into opportunities to meet people where they are. We get into opportunities to really achieve more effective outcomes for the variety of needs that people are presenting with. Next slide, please. So, yeah, there you go. So I want to challenge you guys to think about this today as we get into CIC, community initiated care, and your work. If the assumption is that a fundamental barrier to access appropriate care is this widely held belief that we can only go to certain providers, what happens if we challenge that notion and say, well, what if we reconsider what gets done, where, to whom, and how? It's a totally different paradigm for care delivery. And if you unpack the literature just a bit more and you begin to kind of get into what goes into effective interventions for mental health, the literature is very clear. 80% of what leads to an effective mental health intervention, meaning an effective outcome, is the relationship. Now, the literature calls it something fancy like therapeutic alliance, but truly what it comes down to is the relationship and the trust that you have with somebody in your communities. I want you just to pause for a second and think about the number of people you have relationships with in your communities that aren't care providers. Now think about the number of times that you've shared stories with them about maybe your own struggles or the struggles of your friends or your family. And the number of times that maybe they didn't know what to say to you when you were describing kind of what was going on. Well, this is the opportunity of community initiated care. It's that what the pyramid basically shows is at the bottom part of the pyramid, there's a huge workforce that, if given the right skills and time and attention, could become effective interventionists for things like mental health. Next slide, please. So I want to be clear on two things with this. This is not just about increasing the awareness of mental health. It's not just about educating people on what mental health is and isn't. This is truly about equipping people with the requisite skills so they can be helpful to someone else. So I love mental health first aid. I think it's a great program, but it's very much focused on increasing our awareness and education around mental health. And at the end of a mental health first aid course, I mean, they will tell you that if a person is in need of more help, more care, then you need to call 911, 988, or you need to take them to the emergency department. That's not an effective intervention. It's the reality of the times because we don't know what else to do. But if we are able to look at other countries and we're able to look at the literature, task shifting or task sharing is a very great example of what happens when you can take skills and shift them to other parts of the system. Shift them to people who are already well positioned to be able to be helpful and effective. Next slide, please. So our challenge going into this first breakout is really reconsidering who does what, where, and for whom. When the science is there on training, we know how to train people effectively to deliver mental health interventions. When the science of who to train is out there, meaning we can literally train anyone, anywhere, to do a good job with mental health. The question is, why aren't we doing this? Why aren't we embracing more models that allow for us to kind of equip and democratize this knowledge within our communities? So we want to start with you today. Next slide, please. By just having a small group discussion around barriers. And we really wanted to just kind of break out. We're going to have small groups. So you all will be able to, everybody should have time to talk and just talk about what barriers exist in your communities that are preventing people from accessing the type of mental health care that they need. And then I kind of want to follow that on with, once you get through barriers, if we can get through barriers in the time we have, what are you seeing that might excite you? What are some opportunities within your community? Maybe it's the work that you're doing that really gets you going, gets your juices flowing, gets you totally jazzed about like where you can see opportunities for people to get what they need. And then let's just have a conversation about that. We're going to break out into groups. And the way that this will work, guys, is that Zoom will pop up and it'll say, you've been assigned to breakout group, whatever. Click OK, go to that room, have the conversation. We'll put this in the sidebar for chat if we can. Now that I say that, I think we can. And then let's just talk about this together. We're going to come back as a big group. And then I'm going to ask if each of you can just kind of report out what you discussed within your group. We're going to do this 3 times. This is the first one. So this is kind of the awkward first date. So we're not quite sure how this is going to go. But hopefully we'll be able to learn together and be able to kind of keep going with the next, the couple of breakouts that we have. So Trish, if you don't mind, send us to our groups. This is what we're going to talk about today and for the first breakout, and then we'll back here in just a second. So we wanted to take a minute and just kind of hear from you on what you just discussed. I mean, I took like multiple sticky notes of things that we discussed. I'm really curious if anybody wants to share maybe something that stood out. Let's start with the barriers, because we did get into a few of the innovations as well. But like, what are the barriers that people heard? And maybe the question is not just like, you can list them if you want, but like, were you surprised by any of them, or any of them that stood out to you as like, oh, wow, I didn't know that was that bad in that county? Anybody can just come off mute and speak here.
I mean, I can talk. We, talked about several barriers being like wait lists at current mental health providers and access to care, education around what mental health looks like and how it can benefit someone, stigma, transportation, and like time to do multiple programs, and then a language barrier. So maybe they don't, have access to a specific language there. And then some people wanting it to be in person and some are trying to do innovative things and be like telephonic. And then we talked about funding and how those opportunities aren't as approachable for some, and so that causes barriers.
Really great, Nicole. Thank you for sharing that. Others adding to Nicole or different than Nicole?
I can share. I've
Yeah.
worked quite a bit with the perinatal population in Thurston County. And so thinking about folks with little kids, how do you like either pile them all into a car if you hopefully have one? What do you do with them during the session? Also, some clients I've worked with, like just the social anxiety about like meeting a new provider. I think especially online, right? Even though that's great, like more accessible, but then it's kind of like, what do you mean they're going to be in my house with me? And yeah, just they have a lot of balls in the air, just super overwhelmed parents right now. And so that's been a barrier that I've noticed.
That's a good one. And any parent knows that it's difficult enough to get your kids in the car to go to something they want to do, let alone something they probably don't want to do. So yeah, I'm glad you said that, Amanda, because like that came up in our group too around transportation and the time it takes, not just to take off work and to get there, but the time it may take between your home and the provider in the clinic, and especially in some of our rural communities, the distance that is. And so that is a very big concern. We published a paper years ago that looked at the further away that you are from your healthcare team, however you define that, the higher the likelihood you have profound health disparities, poor health outcomes. And it's just, there's something about distance there where we have a tendency to not want to go. I mean, think of the times we all just stay in when we should be going somewhere else because we just don't want to get in the car. So that's really appreciate your point. Anybody else want to talk about barriers? I want to get into some of the innovations that excite you or opportunities in just a second, but any other barriers that folks want to raise? Y'all are shy in the big group, and we're not even that big of a group. All right, it's all good. It's all good. One thing that came up in our group too, just last thing on barriers, which I thought was a really compelling statistic is, and forgive me, I don't remember the county. If when it came off mute, tell me which county it was. They were describing how there is one provider for every 4,000 people. And so they had basically 6 providers in the county that are able to, deliver and support mental health services, which sounds horrible. And the wait times are 4 months. And so that is, I know while you might live in a more urban county that has more providers, the wait times still are to the point where it's cruel. And I don't know how else to say that. And this is not any of your fault. It's just the system that we have where people in their most dire distress have to now wait to be able to get someone to help them. It just makes no sense. Think of anything in your life that you have to wait that long for. I mean, a baby, maybe. I mean, like, there's not much that you have to wait that long for. You could go online right now and order this tie from Amazon, and it'll be here tomorrow. But healthcare, one of the most intimate things, we have to wait. It doesn't make any sense. Okay, let's shift just briefly to what innovations did you hear that might excite you? Our group was just getting into this when we cut off, so I'd love to know if any innovations that emerged from your discussions.
I guess I'll go because I really struggle with like long pauses and silences, so it's terrible. But anyway, so we talked about obviously telehealth and how beneficial that can be, and not that it's super new, but it's still valued. And then what really the conversation kind of shifted towards us getting excited talking about how there seems to be like just a lot of value in the idea that the community initiated care is actually like reinventing or re-inspiring what is, I guess, a cultural model or group or idea that used to always be back in the day, back in the past. That's how people operated and worked and lived before we really turned into a predominantly individualistic society. you know, on the whole, like people kind of like, you know, you have your husband or your wife or your spouse or your partner, whoever, and your children, and you kind of just all stay together versus back in the day when it was, you know, intergenerational was just super common in the home, all of that stuff. And then within that, the expanded cultural model that was your family now is the idea of community initiated care really brings to the forefront the idea that you're not alone, and the expanded offerings of, you know, having just a bigger group of people that you can draw from, because they understand or they've been there, they have lived experience, what have you. And so that was something that we kind of were starting to really get into, and then we're pulled back in, but we all found a lot of value in that. And as far as this model, so.
Yeah, that's great, Michelle. Thank you. I should have probably said, yeah, we'll talk about that. I'm a clinician by training, and so I'm really comfortable with long silences.
I
So
thought that. I thought he knows to just wait.
you gotta wait. You gotta wait. People will tell you all kinds of things if you just let them sit there and stew on it. So thank you, Michelle. Now I know you're going to be the one that comes off mute. It's great.
Okay.
Any other innovations? I saw, Trish, I think you called out some of the peer support stuff. We did talk about peer support programs and things like that. We had an expert in our group that was focused on eating disorders and talked a lot about the peer component of that, which is great. Again, like the telephone, there's nothing new with having people that have been through what you've been through that are able to help you. But we're now figuring out a way to kind of scale that up within our communities. That's great. Any other interventions? And then we're going to go on. We got 2 more breakouts, so you're going to get more time with your people.
It wasn't me, but so someone else was the expert, but I was excited about some programs that were shared that were meant to connect folks, just kind of in an informal social way. So we had someone from OAAA in our group talking about this really amazing program they were working on of, just reaching out to folks to say like, how are you doing? And then whatever they share can get integrated, into their other services. Just so that there's kind of extra eyes and ears on folks asking them intentionally how they're doing, and then integrating that information about updates. So if someone else wants to share more about that, that would be great. But I was pretty excited about that program.
This is Christina. And so that program is part of a new area plan grant that we're offering through the Southwest Washington AAA, and really actually leverages some of the workforce from a home care agency who maybe don't have the physical capacity to be in home and providing hands-on care, but certainly has experience in providing care for individuals, personal care usually. And really, they work with that particular person who's interested in receiving the call. And then if there's things of concern, then they can share that back. And then if appropriate, the case manager can reach out to that person and do additional follow-up. And just really appreciate it because it's, while it's not mental health services, it's helping to engage early on in the care spectrum and maybe can help be preventive versus, moving to a crisis situation.
Oh, Christina, I love that. And let me just kind of challenge. I actually think that is a mental health service. Anytime you can do something that helps alleviate a person's stress or anxiety or concerns or whatever, that's effectively a mental health intervention. We talk about this all the time. I am in this fancy office today, and I had a meeting with some folks, and we were talking about how some of the most profound mental health interventions have nothing to do with mental health. They have all to do with things like, do I feel safe? Do I feel secure? Is my kid okay? Do I have a job? And that stuff those are interventions. So I love the fact that, you have people that are coordinating and holding hands. And just imagine if they had like one more little tidbit to their arsenal, where if someone said, oh, and by the way, I'm just really feeling pretty down, and they could say the 3 things that could help that person feel a little bit better. So I love the fact that you highlighted that. And I do think that those are indeed, while we would never classify them as mental health interventions, they help people. And that's
I appreciate you sharing that. Our hope is that we can have a program similar to that in each of the counties that we serve. So
that's amazing. I love that, Christina.
thank you.
All right, well, let's move on because we're going to get some more time with each other here. So, Cassie, go ahead and skip to the next couple of slides. Let's do one more. Keep going here. All right, so I talked about community-initiated care, and I think you guys got the gist of it, but let me break it down just a little bit more. Because some of the issues that were raised by many of you in the breakouts or by my breakout group, one of you, will generalize, was around, not having enough people that spoke the language, that were culturally diverse, that looked like the people that needed the care. So community initiated care is doing this model with the people who are already in those communities that look like you, that talk like you, that know the places that you get your food, that know the places that you worship, that know where your kids go to school. They have this relationship of familiarity that puts you on a very different playing field than when you go to a hierarchically and kind of powerfully misaligned system. Not to say that we shouldn't focus on the system, it's great, but like this really corrects a lot of that immediately. So there's three components to community initiated care. One is what I talked to you about earlier, is task sharing or task shifting. And that is taking skills that someone like myself might have as a psychologist and then teaching them to someone else. So an easy example of this would be what we would call like behavioral activation. Okay, it's a very simple tenet of cognitive behavioral therapy. Behavioral activation is all about, and forgive me for those of you that are clinicians and this is your world. I don't mean to simplify it too much, but like this is all about getting people to make a behavior change. Because what we know is when you can make a behavior change, it affects how you feel, it affects how you think, it gives you this sense of, oh man, I maybe I can do more than I thought I could do. That is such power. And so having people that might be working with someone that's experiencing depression or anxiety, getting them to make a behavioral change is almost one of the biggest and most powerful things you could do. So why not take that skill and shift it to the people that Christina mentioned that were on the phone with somebody and coordinating care? Like, let's give them the opportunities to have something where they can help someone, transition and move into that behavioral activation space. So that's the first bucket. The second bucket is around empowerment. And this is really where we get communities that are positioned in these places to believe in themselves. I just talked yesterday to a group of faith leaders. And so when you think about our clergy, we think about the people that represent the faith community. They often are well positioned to be effective interventionists around mental health and substance misuse, but often they don't feel empowered to do that. You might have community health workers, which I know some of you are and are out there doing this work. You might not feel like you have the skills or are empowered to do that, or might not have been given the flexibility to do that. So by empowering people to know that they are the best and probably most important front line and first line of defense against problems and teaching them how to do that, that's really what goes into CIC, community initiated care. And then the final piece is that this is all good. And like, yeah, I hear you, Miller. This is cool to talk about it. But like, how do you actually implement it? Well, you have to have some reliable person that's doing the training and providing ongoing support. I went through way too much school, to get to a place where I could see patients. And that we have licensure for a reason. We have credentialing and certification for a reason. And it's generally to protect the public and to make sure there's a certain standard of care. That all doesn't go out the window. What we're basically saying is that we need a new method of action that allows for these folks in communities to be equipped with the skills, consistently trained over time to achieve quality and effective outcomes. Why not? Because if we don't do that, my friends, I worry that we're up against this never-ending cycle of people getting worse, going to the emergency department, going to seek residential care. Somebody told us that for eating disorders that 80%, maybe it wasn't eating disorders, sorry, now that I say it out loud. I don't remember the number. This is what happens. You write Scrabble down on a sticky note. 87% of the folks that needed care were sent out of state. Well, that's a totally disruptive experience for that family and for that loved one. CIC can help with that because you're going to find the people in your community that can do some of the work. Next slide, please. So I'm not going to bore you with this, but I have to tell you some stories because this is so much fun. Folks across the world already do this. So this is an example from a Dutch supermarket called Jumbo. They noticed that over the years that there were people that were coming to the supermarket and they were in line not to buy a bunch of groceries just because they wanted to talk to somebody. They just wanted to have a in real life interaction with another person. So what Jumbo did was they created a special line they called Klatskasa. And that basically this line was just for people who needed to talk. And yeah, you could buy your oranges and your milk and your bread and your whatever else you need, but they weren't rushing people to get out of line. They were giving an opportunity for people to have an engagement with another person. I can't tell you how powerful something like that is for a person that's feeling lonely. I was with a friend in New York a few weeks ago, and I saw him at like 8:30 at night after a meeting that I just got out of. And I rang his doorbell, and he came down and he said, "You were the first person I have seen all day." He's older, and it just broke my heart because there are so many simple things like this that we can do that will have a powerful effect on our communities. Next slide, please. Easy examples: schools. Our kids spend more time at school as they do with us at school than they do with us, right? And so schools are a place that we could talk a lot about, like how to equip our teachers. I'm a former educator. Like I know we don't want to ask too much of our teachers, but teachers can have skills to help. They're often the ones that are identifying issues in the first place. Connecting those teachers to someone in community that might be able to help next is so powerful. We don't want to reinforce this idea where just because a kid's having a trouble in school, that the police are the only people that can get them from point A to point B, which happens all the time, especially in urban settings. Teaching our kids how to know how to help each other, that peer component, it's huge. And then integrating schools, which I know some of you are doing, within the broader health ecosystem, so that the schools are not just seen um, as just kind of the place that kids go. It's seen as another component of how we achieve population health within our communities. I see the line here. Thank you. The majority of our youth mental health programming is now school-based. That I love that because you're going to where people are. Ali, not to call attention to you, do you want to say anything else about that? That's amazing that you're doing that.
Yeah, I was just going to say that it was a shift that we made this school year because we were noticing just a lot of barriers with families getting kids to our building for after school and evening programming. And families were starting to request stipends for gas cards, and it wasn't an expense that we could afford. And so in the fall, our program manager and our youth team started connecting directly with school districts so that we could be more of like a club-based programming in schools. And it's just like, yeah, go to where the people are. So it's been working.
I love that. It's so inspiring because that's what we should have always been doing for healthcare. And if you go back into some of the original envisioning of what community health centers were to be, it's in the communities where people are. And in many cases, that may or may not be the case these days, but it is always the dream of we should be where people are. So I love that you're doing that. Next slide, please, Cassie. Barbershops. Hello. I mean, I don't have any hair to cut anymore, but I can tell you right now that my guy Scott, when he used to cut my hair, I told him everything under the sun. And so when we have these relationships with people, like imagine what happens when they are able to then help you and not just say, oh, that must suck, but say, listen, have you tried to get out and walk a little bit more? That probably would help you when you get off work. It make you feel better. It release some of those nasty things you got in your body from just being stressed all day. Just imagine what would happen when our communities do this. I work with a man who created a program that trains Black barbers to address mental health in Black men. It's a powerful intervention. He's in like over 650 barbershops, something like that. And it's to normalize a conversation that has been historically stigmatized. It's to give people the space and the freedom to want to go into depth on something that they're terrified to go into because they're perceived as like, well, not man enough. Somebody on our breakout earlier talked about pulling yourself up by your bootstraps. That mentality is still very pervasive. Next slide, please. Primary care. I mean, if you look at my track record, most of my life, I've been trying to convince people to bring mental health in primary care because it's the #1 stop for most of us in our journey for healthcare delivery. Sandra, sorry, this is awesome. Can you say more about that? That's awesome. I love that your husband's doing this or is a barber.
Yeah, it's just it's his personality too. That's obviously why we're together, right? But yeah, I would start coming home. I've only done this for 5 years, and I would just give him little snippets, obviously no names, and he's like, "Oh, I have a client who's going through that.
Yeah.
What did you do? What did you tell him? So now
Mhm.
he's just passing it along. He's like, hey, if you tried this organization over here, and it's
Mhm.
awesome. It's awesome. Most of his clients, because it's a barber shop, not a
Yeah.
salon, are, over 40. So we're in a small rural town who needs a lot of help for our senior services here. So
Mhm.
yeah, it's just we're kind of tag teaming it. It's working out really great.
Oh, I love that. Thank you for the story. That's a beautiful thing. And there's an opportunity here that I think we'll see quickly emerge where each of you have a moment where you might be able to provide that information like Sandra, you do with your husband. I love that. But not just to pick on barbers. I mean, salons, you guys get charged twice as much as we do, and you spend twice as long in there. And so there's an opportunity to have, again, salons, barbers, nail technicians, um, massage therapists that can address like body trauma. I mean, there's so much that we could do in this space. Going back to primary care for just for a second, this is low hanging fruit, in my opinion, because this is not necessarily the community based side, but it's an easy place for us to kind of meet people where they are and have mental health clinicians embedded in primary care. It's a simple thing. We've been talking about it for 30 some odd years now, but we're just slowly still trying to, starting to see people, get this, have it uptake within our healthcare systems. Next slide, please. Okay, so I'm almost done with this because I want to get into another breakout with you guys. But we did write a paper. It's really nerdy and academic around the theory of change. And this theory of change is important because as someone who cares deeply about impact, for me to talk about these things intuitively and logically, a lot of it makes sense. What we wanted to do is really make it scientific. And so a lot of what we went into the process of doing was to determine what are the various factors that go into creating the model that we now call CIC, community initiated care. Next slide, please. So we did what you see here on this slide. And then we did this ridiculously horribly formatted slide that is, if you wanted a good example of a bad PowerPoint slide, this is it. This is exactly what we came up with. And let me just kind of tell you what it says without you having to hurt your eyes reading it. Basically, by breaking away from traditional models that rely on you to only come to a clinic and only see a licensed provider, you can create more opportunities for intervention. We call these pathways. Next slide, please. I'll get into this second. And I'm not there yet. But I'll come back to the pathways in a second. Now, keep going, Cassie. This is fine. So of these 10 things that went into our theory, you can see here that there's so much that it takes to actually make this happen in a community. And so while we're talking about this like you could do it tomorrow, I want to be very clear that there is a larger conversation that must unfold as to where something like a community initiated care fits within your ecosystem. How does this align or misalign with current strategies? How do we use this as a model that complements rather than detracts from some of what we're trying to do? And this is really the process that we went through to come where we ultimately came out with the CIC language. Next slide, please. Back to this slide. So now this slide makes a little bit more sense because now when you look at the bottom of the slide and we talk about community initiated care, you see it's the foundation for the pyramid. That for us to be effective at ultimately intervening within our communities in a timely manner, you have to have this part of the pyramid. Now, I want to be clear, this does not take away from the top part of the pyramid. What I'm not trying to tell to you today is that we need to train everybody to do mental health care because we're going to put the providers out of business. No way. It's never going to happen. What I'm proposing is that we create complementary strategies and pathways to allow for people to get the help that they need and get to the most appropriate place they need for that help. And I totally agree, Ali. I totally agree with you that it does make it more sustainable because as we talked about earlier, when you are a family member waiting 6 months to get access to a psychiatrist, and you can have someone that can help you in that moment today, it's going to decrease the demand on the top part of the pyramid, ultimately opening up, more capacity for them down the road. So I agree. It's a very complementary strategy. Next slide, please. CIC does these two things at once. And this is probably the most important thing I will say to you today. Because when Cassie and I and Trish started talking about like, what do we want to do with this workshop, I wanted to be very clear that this is about connecting the clinical world to the community world in a way that allows for us to have seamless pathways for individuals. So CIC is a new care pathway. It is not replacing the care pathways. It is a new care pathway. So if you're the barber, let's go back to the barber example. We'll pick on Sandra's husband here. He's seeing somebody in the shop that day, and they express ideation, suicidal ideation, or they express that they just really can't figure out a way to drink less, or they just say, you know what, I'm really trying to figure out how to manage this anxiety that keeps me from going outside. If Sandra's husband was able to say a couple of things that allowed for them to move forward, that is a new care pathway. It is a new care pathway. And honestly, my friends, for those of you that have been in the system and gone through the system and maybe been or currently in the system with your friends or your family or yourself, it's not always the best place to be in the system. It's frustrating. It's not always filled with a lot of hope and opportunity. It's really challenging. And so having someone that can immediately set you on the right course and normalize that mental health can be effective is just probably one of the most powerful things that we could ever do to make the system actually more effective. But it's also a career pathway. And I want to acknowledge this because some of you that are working in rural communities, you're never going to be able, no matter how much funding might exist to recruit providers to your area, loan repayment programs, you're never going to have enough. The best way to have providers work in your community is to train providers that are already in your community, to train them that are already there. So this is a new career pathway. There might be someone that is doing this type of work that never knew they wanted to get involved in mental health, never knew it. And then that opens up an opportunity. Maybe then you step in and you give them the training. Maybe you step in and together you put together a couple pennies and you put them in the community college for some type of degree. Maybe you provide your location to be the training platform for 20 farmers that care deeply about helping each other. All of this are new career pathways. And I don't know how else to say it, but we are never going to have enough slots in medical school, slots in graduate school, slots in college that give us the number of providers that we need. But we have plenty of people out there. And you all have plenty of places and spaces that they can go into. These are new career pathways for countless individuals that didn't know mental health was their thing until we made it their thing. Next slide, please. Okay, back to us, small groups. We're going to break you out again, and it looks like we've only had minimal attrition here. So hopefully you will not leave us as we kind of wrap this up. We're going to do 2 more breakouts quickly. How would you adapt this model to fit your communities? We already heard a little bit from a couple of you. What are some examples where we can better connect the clinical and the community? Maybe you're already doing something like this. Let's hear about it. And then what fundamentally do we need? What's missing to make this work? If we believe that there's this like future vision out there where CIC has got some traction, what's missing for making it a reality? So Trish is going to do her magic. We're going to disappear, go to breakouts. Well, thank you. Would love to have feedback and thoughts about this. Cassie, I'm going to pull an audible here because we got a smaller group now, and I think we can just kind of stay together for this last half. We won't break up again. For those of you that feel comfortable coming on camera, stay on camera. Those of you not, that's okay. Anyway, thoughts that folks have. We had an amazing, like, inspiring conversation in ours, and I wanted to have it for another 2 hours, but we couldn't. Anybody want to share some of what you discussed in your breakout group?
I suppose I'll go. Hi, Dr. Miller. I really appreciate all of the information that you've been giving us, but especially you touching on rural communities, as rural health is one of my passions. And integrating community and clinical care. I am a nurse, and I went back to do my DNP in public health nursing because I think a lot of clinicians who go into public health have the same story, but you see your patient in front of you and you try to help them and they keep coming back with the same issues, and it's because it's nothing that you can prescribe to help their issue. It's all of the social determinants of health that are surrounding them that are keeping them from being able to improve and succeed in life in those areas. So this is really a topic that is very close to my heart. And so thinking about the ways that the community and the clinical side are coming together is actually part of my new job now at Choice, which I'm really excited about. And I feel like one of the big missing pieces is that the system complexity gets in the way, right? There's so many different players, everyone's on different schedules, they're at different places, they have different um, formulas, so to speak, that they have to adhere to. Like, this is my lane, and these are, what I can do, and I can't really move outside of these confines. And so, how do we cut across all of the red tape and and just some of those structural things, like some people work night shift, or some people, they work like far away, or they don't have the internet, or whatever, um, that really are keeping us from being able to collaborate more effectively.
Really, really, really helpful. Thank you for sharing that. I'm sure many folks here resonate with that and could speak more into it. That's such an important point that I think we could spend a lot of time on. So thank you for that, flagging that. Others want to share just here.
One of the things we talked about, especially being in the rural area, is how would you adapt CIC to fit your community? And someone had already mentioned in our group that, and you had too, that, we already are kind of, if we don't have the funding, like everyone said a million times already, we make it work ourselves. So it's kind of exciting to know that the rest of everything else is going to be kind of joining the group too, or the conversation at least. So that's really exciting.
Yeah, funding definitely came up multiple times, I'm sure throughout all the groups, and we will talk about that here in just a second in our last half, but really glad you raised that too. Anybody else want to just comment briefly?
I don't want to speak for our group, but there was a couple questions that folks brought up that I'm sure you have heard many times before, Dr. Miller. So like, as it's helpful to address them now, or just think about how we can share out information after the fact. But folks asked some questions about like HIPAA and, okay, people are sharing this information. What are our considerations? Others asked about, potentially well-meaning folks who get trained but may have their own stigma and biases that could actually be harmful in connecting with people in vulnerable situations. So all great questions that just wanted to raise up, that I'm sure you have heard and discussed many times, but I thought they were great considerations in our group
Yeah,
conversation.
Absolutely. These you guys are so on it. These are details. We had some similar conversations, like how do you protect the safety of people? Absolutely. So I have two responses to that really briefly, and then we can continue. One is that these conversations are already happening. They're already happening. People are disclosing what's going on with them. They're telling their story. They are describing their pain. They are going through their suffering. And so they're already telling you what's happening. So by default, they're kind of in a position of they have the power, and they're giving that up and telling you what's going on with them. So what's the difference here is that we typically don't know what to do in response. And so even if you're a well-intended person and you may not have the skills to know what to do in response to that. So HIPAA becomes like this, almost like this healthcare wall that we hide behind, where it's not honestly a problem when you're approaching it from the angles that we're talking about here. We're not a healthcare provider per se. You are simply a member in the community that is being given training to help someone else. Now, our group, Michelle Watt raised this in our group. Sorry to call you out, Michelle, but like, how do you make sure that people aren't doing harm, to your point, Cassidy, around this? I mean, like, to me, that is a very important thing that we have to discuss. Folks should go through proper training, and they should be held accountable to deliver quality for whatever they're doing for their training. We were talking about barbers have licenses. That's a part of that. What happens if a part of a licensure test for a barber is that they know how to answer 5 questions around suicidality? So you can automatically start to build things in that still provide that general protection for the public. Well-meaning people that cause harm happens all the time. And honestly, we cause more harm by being silent than sometimes the things that we say that might be, misconstrued or taken the wrong way. So I just feel like the cost of doing nothing is too much, and that we have to take some prudent risk here, and we have to set the conditions that allow for people to have these skills, and we have to make sure that we are surrounding it with some type of organization, like any of you on this call, that can make sure that people are doing what they're supposed to be doing. That is pure and simple. I'll give you one example from the literature. So a lot of this model one of the models that we seem to be most effective happened with community health workers in India, in these villages in India where there were no providers. And so they trained community health workers to deliver evidence-based psychological interventions for depression. And what they found was that these interventionists, these community health workers, had a more profound outcome on depression than licensed therapists did in terms of maintaining remission for depression. And it doesn't surprise me, probably didn't surprise you, because they knew them. They had these relationships and they were able to do very brief interventions with these folks. If you look at the work that's been done in like Zimbabwe around the friendship bench, okay, this is a very basic, if you guys are familiar with this, it was on CBS last week, actually. We can pass along the link to that. There's a psychiatrist that lost one of his patients to suicide and was absolutely mortified because he was the only psychiatrist in his entire community. He's like, I have to do more. So he created a friendship bench, and he trains grandmothers, the matriarchs of the village, to deliver evidence-based cognitive behavioral interventions to anybody that sits on the bench. I mean, so there's ways to do this responsibly that still allow you to control for some of those things that make us really worried. But I just have to say, like the cynic in me, who has been around healthcare way too long, is that the cost of doing nothing is far greater. And I just think we have to be a little bit different and think differently about this. It's also, sorry, now I'm going on a rant. I don't mean to, but it's also where the biomedical model has broken us and convinced us that there's only certain people that can do certain things that solve certain problems. And I just don't think that's true. Ali raised that in ours about the differences between East and West medicine. So great conversation, great point. All of these things are problems that can be solved. And the good thing about us, and I alluded to this, is there's actually science that we can point to and examples of where this is being done already. So we're not starting from scratch. We're not trying to create a revolution per se, but we are trying to scale up something that is revolutionary. Okay, let's shift because we got about 20 minutes left, guys, and I want to make sure that I'm protecting your own mental health and giving you a break between your meetings, hopefully. So, Cassie, we have the last section. Do you mind pulling up? Man, you guys are so good at the chat. Ali, I'm going to call on you because this is too good for you not to share. Do you mind telling your story really quickly?
Yeah, I was just gonna say, during my time in Peace Corps Tanzania, I was working at a pediatric HIV clinic, and we were a part of a project that was training taxi motorcycle drivers in emergency medicine, because often they could weave through traffic quicker to respond, and they were more embedded in like community neighborhoods to be able to provide emergency medical response rather than like the one ambulance that maybe worked in the town. And it was so effective.
Yeah.
And then those people are then family members, right? Like in neighborhoods. So
That's
it was
right.
really cool.
It's why in certain parts of the world, in certain communities, it's why community health workers do minor surgery and vaccinations. It's the same thing. That's task shifting. That's exactly what that is. And so it's just an application of that for mental health. I love that story. Thank you for sharing that. It's beautiful. Cassie, can we go to the next slide, please? Yeah, we already did that. Okay, this is the last section. So I want to own this up front because like for me as a policy guy, like it's so easy to enter into conversations like this and tell you all the reasons why we can't do it. And to get into, well, we can't support it financially. We can't, figure out a way to find the people that want to do it. This is a very policy heavy slide, but I just want to name it because like there are so many places around workforce development for mental health that we could have influence that is even outside of CIC. So just marinate in this for a second, because there's so much here that we could get into that I think, your state could lead on when it comes to really rethinking a lot about your workforce. But I want to just kind of back up even from this, because this is really wonky. And let's talk about what we can do together. Now, this is where I'm going to kind of put the pressure just a little bit on you all. My daughter, my oldest daughter, we were in the car recently, and she was listening to me get off a phone call, and I was talking about some statistics around youth and just some troubling statistics that I'd seen in a community. And she looked at me, as she's want to do, and she said, "What are you doing about that?" And I felt that so deeply. I've done a lot of really meaningful and impactful things in my life, but for my daughter to say, challenge me, like, what are you doing about that? Reminded me that we, and this is us, all of us on this call, we're the leaders in this moment. No one else is going to come save us. No one else is going to step up. Like, we are the people. You are in the positions that you're in, and you are there, are able and capable to do something about these massive problems that our communities are facing. What action can we take together? What do we need to do to better address issues of mental health? How do we normalize and socialize community-initiated care within our communities? That's the last part of what we're going to talk about here. So, Cassie, if we can go to the next slide, please. Nope, that one. We're not going to break into small groups. One back. There we go. But let's just talk as a group now. We can take down the slide. Actually, if one of you guys can just pull that into the sidebar so people can see the question. What's something that you all could do today to really bring a model like this forward? Assuming there's value, assuming it makes sense, assuming that there's a need. Like, what's something that you could do today? And then thinking outside of that, who might you need to partner with? Are there folks that are on this call? Are there folks in your community that you might just kind of say, hey, listen, I really need somebody that could help me with this? So, like, well, let's move to action here. Cassie's going to close us out here after this discussion with choice and the unique role that choice plays, which I think is brilliant, and I'm really glad to be a part of this. But I'm just curious, like, what's something that you all might be able to do to advance this work? Who might you need? And how do we keep this movement going instead of it just being a really kind of fun and inspiring call on a Thursday?
I don't know. Is my mic on?
You were on,
Oh,
Michelle.
okay, thanks. I think that when you touched on it earlier, as far as, not leaving it to the idea, or I guess like helping and working to get it away from the idea that mental health is only to be handled in a clinical setting, and reframing it as a community issue, not a clinical issue, I guess, and then promoting that idea to the people that you already have contact with, people that you already have, those daily interactions with community members, teachers, employers, coaches, I guess, neighbors, anybody, your clients, people that you already, that can all play a role in support of the idea that mental health is not a clinical only, I'm drawing a blank on the word, but I guess that it's everybody's responsibility. It's not just the clinician that's in a room or on a screen's responsibility. It's everyone's responsibility. And normalizing that with the people that you already have credibility with, that you already have rapport with, that you already have communication with, and really lending to the idea that we are already natural helpers just by human nature, and then somehow moving from that, or maybe already having it set up, as far as like empowering them with that basic mental health training that you're talking about.
Yeah, I love that. Thank you, Michelle.
Mm-hmm.
Morgan, you made a comment. Do you want to come off mute and say it out loud?
Yeah, my voice is kind of froggy, but
Okay.
I will try my best. We have a meeting with our mental health volunteers coming up in a couple weeks that we do we try to do it every quarter. So I'm thinking of adding this to the agenda and talking about some potential ideas there. It's between our mental health volunteers and our patient care staff. So I think we could come up with some things then. And we also have a separate meeting with our medical providers, who are all volunteers, and there's typically some wonderful brainstorming that happens at those meetings. And so I'm thinking that can be a good outlet too for this.
I love that. I will say from experience, the conversation that you'll have with the medical providers versus the other staff is going to be very different. And I kind of alluded to this earlier, but and some of you got to this, and this is with tremendous respect to all of you that are providers. But there is defensiveness and some reticence on the part of the medical profession to relinquish some of the control to allow other people to do what they can do. And that shift in culture, that shift in skill is grounded in evidence. And there's nothing that says that just because you have this degree, you're the only person that can do it. We need to make sure we do it well and do it right. And that's the training and the certification, whatever else it is. But I will say, in my field, having talked about this for quite a number of years now, mental health professional is always like, well, you could never do what my 7 years of training got me to a place of being able to do. And I'm like, you know what? I don't think they need 7 years of training, and a lot of what you do doesn't help many of the people that you're trying to serve. So it's a very different conversation. I'm really glad you're going to have it. Cassie, this is just for our little homework assignment. If for slides or articles or videos or whatever, like help us let us know what we could do to support you, because we want to make sure that you go into those meetings most prepared to have that conversation.
Thank you.
Yeah. Anybody else want to jump in on the actions? Hey, Debbie.
Hi. Hey, I work for a managed care organization, and I have to really, I would love to present this to providers, and I get it. They might be reticent with it, but I think this is really, it's an adjunct to what we're already doing provider wise. But I think if I would love to, if Cassie or somebody from Choice or anyone come to present it to the providers in our 5 counties or 7 counties actually that we have, to get this message out. So
yeah, I agree. I don't mean to be so doggedly that people are against it. I think when you frame it the way that we've tried to frame it today around that pyramid, that this is extremely complementary, and that people will see where it's value add. Yeah, and don't forget, years ago, guys. I mean, we used to. Some of you were community health workers. Years ago, there used to be a big push of why would we let community health workers do this, or why would we let pharmacists do that, or why would we let dental hygienists do this? I mean, there's been always this challenge of like protecting yours because it's yours. And the only thing I can say, and this is a really fun thing, you can use this with your kids and your friends. It's the most powerful intervention that you could ever use, is you just ask people if something's working or not. And I think that many of us would be hard pressed to put ourselves in a position where we could say that across the board, unilaterally, what we're doing for mental health in our communities, especially rural communities, is working. So we have to try something different. It's my comment that I made at the beginning about structures. We all inherited what we are currently doing from someone else. And if we could start over and just kind of push a reset on the Nintendo, what game would we play? What would we do? I think we would probably create a very different system with different values that was financed differently. And all of us would do that. We can't. So we are doing the best we can with what we have. And this is a fundamentally, if I can use this term without sounding too glib, but this is counterculture. Dominant culture is to go to the clinic to see the provider. Counterculture is like we're working actually in favor of the people who need the care the most, and in those communities. Yeah, Allie, go.
Yeah, I appreciate you saying that, because that has kind of been the thing that's been really at the forefront of my mind. This whole conversation is like the way, and our organization does a lot of work in anti-racist education and really like practices around normalizing how dominant culture and these ways of being in community cause a lot of harm that are really rooted in white supremacy traits, and how that scarcity mindset has really like seeped in and like causes a lot of harm and hyper individualism, and like really like the list goes on, obviously, of how the ways that power moves, particularly in these conversations, that's like, oh, I can't have that conversation. I don't have like these letters behind my name. Well, I can't access a degree because I was raised by a single mom who had all, I mean, like the list goes on. So like even zooming out and looking at it systemically, it is so clear to me why this model is so needed, and all of the barriers that come along with like deconstructing my own ways of thinking that are like hindering my ability to actually cause real change. And I think that we're doing that, like all of the workshops that we're doing and conversations that we're having with people and ways that we can continue to like disentangle from those characteristics help. But like, yeah, that scarcity mindset of like, oh, only these certain people can do this thing, or there's one right way to do this thing. Like we're not going to move forward if we don't like individually and systemically really like divest from the ways we've been taught that there's very specific ways that this can or can't be done. It's my
I love that.
soapbox.
Yeah, no, that's beautiful. The scarcity mindset has rarely, if any, ever gotten us anywhere. So I really appreciate you saying that. I mean, this does fundamentally, to your point, it flattens the hierarchy and redistributes the power almost simultaneously. And it complements the system, but it actually shifts the power back where it should be, which is in the pockets of those in community, which somebody said this earlier. But I'm going to paraphrase in a different way what they said, but the oldest and most powerful form of medicine that we've ever known is love. And not to get all touchy-feely on this, but truly, like people need relationships, they need to be heard, they need connection, and they need folks in community that they can relate to. And mental health is so much more than just, anyway, I'm starting to do my mini TED Talk now. Joyce, please jump in here. Dr. Heck, excuse me.
Oh, that's fine. Thank you. So I guess from my perspective, I really liken this to CPR on a broader level. Like no one ever says, oh, don't teach people CPR because they're not paramedics or they're not, EMTs or, ER doctors or whatever, right? Like we know that CPR saves lives, but how often are people going to be in a position to utilize it? This is a much more pervasive issue. Obviously, you've spoken to that effect, and people in general are in a much more immediate place to give that intervention, and you don't have to be, as you've said, you don't have to have all of these like skills. You just need a certain set, and that's the first intervention right there. Everyone can have knowledge of CPR and first aid. Not everybody needs to be a clinician.
Yeah, that's really good. That's really good. I like that. CPR is a great way to put this. And I think about it, it's like it's CPR when there's the emergency, but it's also all the other skills that prevent you from having the emergency. It's like, oh, have you started to exercise? Are you eating leafy vegetables? Stuff like that goes into it as well. So it's like if it gets to the heart attack, then I can save you, but it's also the prevention component too. I love that. Well, I want to just kind of end by saying thank you. I appreciate you guys hanging in there for 2 hours. It's a long time to be on camera. It's a long time to have a conversation, especially about something so new. You all are amazing. You're so inspiring. I just want to thank you for being the leaders that you are, especially in this moment. I know we have a lot to think about on our internal team, but Cassie, I want to thank you and Trish and the rest of the Choice team for allowing this conversation to happen, because it's not, often you find people that are willing to go to this place. And so really appreciate you reaching out and taking a chance on something that could be transformative. So I will let you have the last word and close this out.
Yeah, thank you. Thank you all so much for the conversation and the energy and your experience and wisdom that you brought to all of this. As I mentioned, we've been having some really great and really challenging but good conversations at Choice and with Dr. Miller's help about what community initiated care is, how it could augment our system of care in our region. So I want to highlight a couple things in terms of action that are coming up on the horizon that connect to this related to Choice. So I referenced at the beginning of this workshop that we had convened a health equity cohort. I know Michelle's here from our cohort. And so she was part of that process along with others. And so we convened this cohort as well as our tribal partner relationships with the intent to draft a regional health equity improvement plan. So that plan is in the very, very final stages of being finalized, and it will be on Choice's website very soon, if not this week, early next week. So we will make sure to share out the link once that plan is published with you all. We are very proud of it. Our team has worked very hard on it. Along with the thought partnership of everyone in our cohort and our partners in our region and our other Choice staff. So we're really excited to share that with you all. There's 2 action items related to the health equity plan, other than just here's a document that we hope can be a tool and a resource to you and all of us in our region. One is that we are going to be opening an application for Health Equity Cohort 2.0 in the coming weeks as well. That will be focused on engaging in our health equity plan, what we heard, what we're identifying as strategies, how we see this work rolling out in our community, what that could look like. We really envision that to be a shared learning space. We want to learn as Choice what you're hearing and seeing in your communities. We hope people will come to that space with interest in learning about what they can understand and know and gain from partners and how they can apply it to their work and vice versa. So that will be also on our website as well. Trish, who is newly joined our team, will be leading those efforts. So you'll be in very capable hands if you're interested in joining the cohort. And we'll put our contact information in the chat here in a second as well, just in case you want to reach out and do any follow-up. So we have the health equity plan. We have the health equity cohort 2.0 that will be launching to continue those conversations. And in the spring, later in the spring, Choice will be publishing a request for proposals to invest in pilot projects that align with our health equity improvement plan as well. And many of the concepts that we talked about here today with community-initiated care, bridging formal and informal systems, really leaning on the wisdom of the community, particularly those impacted by the challenges that we're all talking about. Mental health is one of them. There's many others. Really leaning on that wisdom to lift up problem solutions and ideas, as well as just centering belonging. So Dr. Miller just mentioned, that was a theme that came up a lot in our health equity cohort conversations of the importance of connection, of human connection, system connection, and feeling like people have a place to belong and a purpose. So those are some themes that have come out of the health equity improvement plan. You'll see them there. Hopefully they'll look familiar when you read the plan. But so our investments through that RFP will be very focused on projects that can help us test what this could look like and start to support this in a organized, sustainable way. Because I also appreciated that Dr. Miller highlighted these models are exciting, but they don't just happen. Adding one more thing onto all of our organizations' plates, all of our staff's plates, our volunteers, our community members, there's interest, there's energy, there's passion and experience there, but without the ability to support that infrastructure, bringing together all of those pieces, we totally understand that can mean that those projects and plans don't go as far as we all would like them to go, and that they can that can help avoid, or that can avoid connecting those in a systemic way or a scalable way. So that is something that Choice is very interested in investing in and in supporting, is infrastructure, sustainability, operationalizing what some of these pilot projects could look like, and then learning from them. So we are really excited to be diving into this topic, to be learning with all of you. And those are kind of the 3 ways that most immediately we can offer to folks in terms of action or next steps, as we will be publishing our plan. We'll be inviting folks to join a cohort, and we'll also have some funding available for pilot projects in the months to come, so we can hopefully continue on this path. So that is what's next from us. Oh, thank you so much, Trish, for putting our contact info in there. And yes, we have a brief survey if folks want to take a couple minutes to just share what they liked and didn't like or would recommend in terms of the workshop today. So that is my piece. Thank you so much, Dr. Miller. Thank you, Trish, for the logistical support. If there's any last minute questions, I think we're all willing to stay on a couple extra minutes, but or if you have questions for us individually, feel free to reach out. We will share the slides and the recording and any other resources that you all request or that we identify that may be helpful, we can share as well.